Good morning, everyone. I would like to thank Dr. Ajit Menon for sparing his time on a Sunday morning. Uh, thank you, Dr. Tushar Shah also. The order in which we'll be starting the question answer is the interview lecture is we'll be having around 15 questions which will be asked by the audience. They have been provided with they'll be provided with a mic. There will be, after asking the question and sir answers, we'll have a opportunity of one rebound question or one question by the same person who can ask a question regarding that same topic, and then we can go forward. So I would.
Before that, I'll take the opportunity of introducing Dr. Ajit Menon. We don't do traditional introductions. I have sent them your biodata, and they have probably gone through the biodata, but I would like to know more interesting things about you. First of all, are you enjoying medicine?
I enjoy medicine, yes.
Are you planning to retire?
I am planning to retire.
And when is that?
I told my wife I'll retire in about 5 years.
5 years from now, so
Yeah.
you are what, 64?
No, I'm 60.
60. So, and your daughter is abroad?
Yeah.
So, one daughter?
One daughter, she's studying she's working in the UK.
As?
She's not a doctor.
Okay. But as what?
She's working as a business development manager for a group called the King's Fund, which is a semi-governmental organization which works towards funding for the NHS and towards government policy. So she's more in the social sector, towards women empowerment and child education.
And people who believe in women empowerment may rarely marry. Is that true? Or will she marry?
Is she mild?
She might marry?
She's married?
I'm asking you.
No, she's not married.
हाँ तो women empowerment वाले जल्दी शादी नहीं करते ये सही है? नहीं.
Nowadays you can't ask your children when they want to get married.
Okay.
You can't even say the word marriage in front of them.
You have a passion in music. What kind of music?
I have learned classical music many years ago when I was a child. After I joined MBBS, I studied for 3 years and I left it. So I do sing once in a while, nothing great. And we have a group called the Tuning Folks, which is a group of doctors who do programs for charity, charitable causes. So once in a while I join them.
Wow. We'll have to request him later for one small ditty. Yeah. So this is how it will go. The audience will ask you questions and
Sure.
we have 3 minutes per question ideally so that we can
I
be on
hope
time.
I can give adequate answers.
Okay. So question 1.
The first question is by Dr. Paresh Savla.
Morning, sir.
Morning.
So, hypertensive 70-year-old lady with LDL 170. A treadmill test is negative. This is normal. Would you prescribe statin for her? And what is your take on non-diabetic as a prophylactic statin?
Non-diabetic as a?
For non-diabetic patients, as prophylactic statin.
Primary prophylaxis in
prophylaxis.
statins.
Right.
If somebody doesn't get the question, you can raise your hands and we can repeat it for you. Yeah. Yes, sir.
I think, today we have, what is the average lifespan of an Indian? An average lifespan of an Indian is technically about 70 years. But it varies between state to state. If you go down to south to Kerala, the average lifespan is almost 78. If you go down to the north into some smaller areas, the lifespan goes down to 63, 64. Indians don't have guidelines in terms of at what age you don't treat or what age you treat patients. The guidelines say that, there are no guidelines for those beyond 75. But up to 75, 2 or 3 of the guidelines say that you need to treat the LDL values to bring it down depending upon the other risk profiles. Now, if the patient is only hypertensive, I would still try to bring it down to less than 130 or around 100. I may not go very high on the statins, but I will not neglect it either. Because there is still data that suggests that bringing down the LDL values might stabilize plaques and might prevent events in the long term. In terms of non-diabetics, as the use of statins, if the patient has a strong family history, if the patient has any other risk factors like smoking, very high risk or a high stress lifestyle, and falls into, and you calculate the Framingham risk score. If the Framingham risk score is more than 10% over a 10-year risk, in these patients, yes, we would give statins. If the Framingham risk score is less than 10% risk over 10 years, probably you would not, you can leave these patients alone.
Any rebound question? Would you have, or we can go to the second question? Yeah, please. Take the mic. Take the mic, please.
Do we advise lifestyle management at that point of time, at the age of 70, before starting statins?
Yes. The thing is, if you, in terms of management of any hyperlipidemic patient, lifestyle is a part of it. But if you expect lifestyle changes at that age to bring down the lipids drastically, it doesn't happen.
So we start immediately.
Of course, it is. I mean, it is a part of this thing. But I would probably give a small dose of statins also to begin, because 170 is definitely much higher than what the lipid goals suggest.
Okay, thank you, sir.
We'll be asked, the rebound will be only from the person who asked the question.
So what about if the age is 75? You do not start.
Beyond 75, the data is less in terms of starting statins. We don't have any class 1 indication. It's a class 2B indication, if you understand. I mean, if you look at the various classes of indication. Starting statins beyond the age of 75 or 80, purely based on no other major risk factors, is a class 2B indication.
Yeah, it's a weak indication with weak evidence. Okay, question 2 is with
Dr. S.G. Rao.
Yes, sir.
Which is your favorite statin? What are your preferred LDL cholesterol target in different situations? And is the target different in the very old?
What do we mean by very old?
About 60, 65.
About 60, and very old, today the classification of old has changed. Okay. So when we say very old, I would categorize the population beyond 80 as being on the very old side. 60, 65 is no longer old as far as the criteria today. Now, in various clinical situations, what are my goals of therapy? Now, it totally depends upon the risk profile of the patient. If the risk profile is high, if it's a younger patient, if has got multiple comorbidities, then my treatment of these situations is going to be much more stronger. I'm going to be much more into the treatment in terms of trying to bring down the LDL goals. If the patient, I mean, it is purely based upon the clinical situation. For example, now if you look at the Indian Lipid Association guidelines for very high risk individuals, a young individual, demonstrated atherosclerotic disease, or familial homozygous hypercholesterolemia, in these patients, the LDL goal is less than 30. So, but how many of our patients achieve that LDL goal of 30 with any dose of statins? Our tolerance for statins is extremely low. Now, I would like to ask a counter question. How many of us look at the liver enzymes and the muscle enzymes when we give patients statins? So, we randomly pick up patients with high CPK values, high liver enzymes, when we treat patients on high dose statins.
even asymptomatic patients.
Even completely asymptomatic patients. They come up with CPKs of 4,000, 4,500. They almost, and this is randomly picked up on routine screening, because we know that these patients are subject to this to this issue, because we're giving them, say, 40 milligrams of rosuvastatin or 80 milligrams of atorvastatin. So monitoring these patients when you're giving these high dose of statins is also extremely important in clinical practice. Even if your cardiologist or a physician doesn't do it, you as general practitioners should make it a point that make it a rule to check these liver enzymes at least once a month, so that you don't miss these patients who otherwise might go into significant non-alcoholic hepatitis, or patients going to rhabdomyolysis with muscle injuries. What is my favorite statin? My favorite statin, I mean, I don't have a favorite statin. Most of the outcome studies have been with atorvastatin. Few of the outcome studies have been with rosuvastatin. in terms of reducing the events, reducing the plaque burden. So the choice between the two remains in terms of which of these statins that the patient tolerates. They say that certain muscle pains, etc., are lesser with rosuvastatin as compared to atorvastatin. But rosuvastatin also has a side effect of increasing the sugars and increasing the HbA1c much more than atorvastatin. So that is one thing that you need to keep in mind in terms of this thing. Other than these two statins, we don't have any statin that we use. But when we talk about high-dose statins, it is either 40 milligrams of rosuvastatin or 80 milligrams of atorvastatin. Combining ezetimibe to the atorvastatin or the rosuvastatin has been shown today to be beneficial in lowering the LDL cholesterol much more faster than just one of these drugs alone.
Very specific in the same question. Your target LDL in no coronary artery disease but diabetes. Your target LDL.
My target LDL would be in diabetics would be less than 70.
Your target LDL in somebody who's undergone PCI, an angioplasty.
Today, less than 50.
Less than 50. Okay. Sorry?
And only hypertensive less than 100 is
said.
fine, because hypertension is not a major risk factor as in terms of coronary disease. So if it's purely hypertensive, non-diabetic, lean individual, no metabolic syndrome, no truncal obesity, we can manage it at about 100.
Let us not take rebounds too many, because there are other questions which will address similar things.
I'd like to ask Dr. Rashmi Agarwal to ask her question. 1 minute, please, Mike.
Yeah, I have a mic.
My question is, those who are post-MI, post-angioplasty, post-bypass surgery, their lipid parameters should be monitored every year, or?
I would suggest that you monitor them at least thrice a year. At least
After
thrice
60,
a year. After 60, irrespective of any, after 60, once in 6 months you monitor them. But if a patient is a high-risk profile, IHT, MI, post-angioplasty, post-CABG, your long-term management depends on how, we can control parameters which are under our control. We cannot control certain non-modifiable risk factors, environmental factors, we cannot control. We can control the lipid profile that is in our hands, control diabetes, control blood pressures. Monitor them every 4 months. Make sure that there are no side effects, patient is tolerating the drugs, and you're achieving your targets.
Thank you, sir.
Okay. Dr. Rashmi Agarwal.
Geriatric patients may have muscle aches due to various causes. How do we diagnose statin-induced muscle symptoms, and what are the options if statins are indeed causing muscle aches?
Normally, like I said again, typically these patients will start complaining of muscle symptoms after you have started the drugs. So a history is extremely important as to the onset of the symptoms. Number two, another symptom that these patients, another typical symptom that they complain of is calf pain and thigh pain. Body aches are very rare, not that they are uncommon, but calf pain, thigh pains are the commonest symptoms. Look at their CPK values, look at their muscle enzymes, their liver enzymes. If they are high, then there is some element of statin-induced myopathy. Some patients will have severe, we have only myalgia. And this may not be picked up on any investigation. If the patient complains of severe myalgia, then you have to stop the statin, because you will have to give it a statin-free trial. And if the symptoms disappear on a statin-free trial, you know that the statins are the cause of it. What are the replacements for statins? It depends upon the clinical scenario also. Ezetimibe is a good replacement. It does not have the same side effects as statins. So some people do experience muscle pains and increase in CPK values with ezetimibe also. The second group of drugs that are today available, the second thing is pitavastatin as a statin, because pitavastatin has a lesser side effect, is the least of the side effects in terms of muscle pains and liver enzyme rise with pitavastatin as compared to other statins. What is the dose of pitavastatin? 1 milligram to begin with. You can go up to a maximum of 4 milligrams. The next line of therapy are the PCSK9 inhibitors, which basically are protein convertase coenzyme and coenzyme substrates, which basically work at the receptor level. There are 2 drugs available now. One is Repatha, that's evolocumab, and the other one is inclisiran, both of which are expensive. But in statin intolerant patients, in patients who do not achieve their goals with statins, mind you, these are the 2 classic indications, not for anyone and everyone who wants to the same. And today we have certain outcome data with Repatha, that is with evolocumab, in terms of reducing events after coronary intervention or coronary artery disease, which show that giving these drugs will reduce the LDL values and they will bring it down faster, thereby reducing cardiac events in the long term. But this is not a drug to be prescribed for anyone with hyperlipidemia. Unless your patient, the only class 1 indication for prescribing these drugs is statin intolerant patients, statins patients who do not achieve their goals with statins, and probably in patients who have a family history of hyperlipidemia and they have been diagnosed to have familial homozygous hypercholesterolemia.
We'll take the fourth question. I think we are a little short of time, so you can ask your rebound, but we'll take the rebound questions at the end if necessary.
Sorry.
Dr. Meenakshi?
Yes. When do we give pharmacotherapy?
Ma'am, the mic.
When do we give pharmacotherapy for high triglycerides to the elderly? What agents do you prefer for the same?
High triglycerides is a typical manifestation in the Indian scenario. So we have a lot of patients with low LDL and high triglycerides. If you're talking about elderly patients, I'm talking about beyond the age of 75. Unless the triglycerides are more than 300 or 350, I would not go very strong on the drugs for them for these patients. One of the reasons being that our diet is rich in carbohydrates. Our diet being rich in carbohydrates itself is known to increase the triglyceride values. So dietary changes to a large extent can change the triglyceride values in these patients. Secondly, when the triglycerides go very high, the risk in the elderly is also of pancreatitis in these patients. So it's not only the risk, it's not the risk of purely coronary disease that decides a treatment for in these patients. The drugs of choice still remain the fibrates. We don't have any other drugs, and especially when the triglycerides are beyond 350, 400. Start off with fibrates and see how they respond to these drugs. A lot of patients complain of gastric complaints, intolerance to fibrates.
The next question, Dr. Preeti Bhargava.
Good morning, Dr. Menon.
Yes, ma'am.
So a 65-year-old diabetic gets a coronary calcium score done. The score is 400. The patient has no cardiac symptoms. What will be your next advice, and what is your opinion about coronary artery calcium score?
This is a very, very debatable topic, extremely debatable topic, because today we are seeing a lot of patients going in spontaneously for calcium scoring and CT angiograms, even without doing a basic ECG and a 2D echo or a stress test. We have forgotten the hierarchy of how to investigate. One of the reasons being that we don't want to miss coronary disease. I mean, I may prescribe no, he may prescribe yes, and then oh, you missed my blockages. Now the question is, a calcium score of 400 falls into a borderline zone. It's not mild, it's not moderate, it's not moderate. I mean, it's somewhere in the middle. In a diabetic?
No, not a diabetic.
Non-diabetic.
Sorry, 65-year-old diabetic.
Diabetic.
Yes,
In a diabetic with a calcium score of 400, I would first go back, do an ECG, echo, and a stress test, or a physiological imaging. If the physiological imaging is significant, if you have a stress test which is positive, then yes, go one step forward. A calcium score does not mean the presence of blockages. It only indicates a higher incidence of blockages. You can have a 0 calcium score and have blockages. You can have a calcium score of 2000, have no blockages also, because it depends on whether the calcium is intimal, medial, or it is adventitial. So purely based on calcium score, proceeding for any further investigations has no locus standi. We also have the ischemia trial, which shows that unless you are demonstrating ischemia, treating a lesion does not contribute to the outcomes of the patient. So purely treating calcium is not this thing. I would go look at a physiological investigation. Is the patient symptomatic? Does the patient have anything else? Do a stress test or a stress perfusion imaging. If any of these are positive, then go ahead to the next step. In terms of what is my role in, what is my view on calcium scoring, I don't think calcium scoring contributes too much. It used to in the past when they used to say high calcium score has a higher indication. Yes, you can do a random screening for a calcium score, but don't take that as a gospel. Look at other preliminary investigations before we reach a diagnostic purely based upon a calcium score.
Okay. The next question, Dr. J.C. Mehta.
Hello, sir. Hello. So in the same connection, how do we decide about whether coronary CT angio or a catheter CT angio in an elderly person?
In an elderly patient, again, if the patient is symptomatic, listen to the patient. If the patient is symptomatic, classical angina, don't do a CT angio. You may do a physiological investigation and go directly for an angiogram. A CT angiogram is in a patient who has a borderline positive stress test, mildly positive stress test. You're not sure the patient's symptoms are fine. Yes, do a CT angio. My suggestion to you is that please instruct most of these people, radiologists, that if the calcium score is high, don't do a CT angio, because you are unnecessarily injecting dye and giving us an unequivocal answer to the lesions, 50 to 60%, moderately severe, moderate to severe. Where do we stand? We still don't have any diagnosis with it. If the calcium score is very high, patient has got a mildly positive stress test, do a coronary angiogram. Again, if the calcium score is beyond 1000, 1500, and in a patient whom you suspect coronary disease, do an angiogram, not a CT angiogram. You're unnecessarily subjecting the patient to a dual dose of the dye at that age when the kidney functions are already compromised, irrespective of whether you like it or not. The creatinine may be normal. You calculate the GFR at the age of 75, you know the GFR is definitely going to be on the lower side.
And is there any difference in radiation exposure and contrast media?
Contrast, yes. Today we can, we can do an angiogram. Again, so I'm sorry, one more answer to this. If the patient's creatinine is borderline, say your cutoff limit is 1.4 or 1.5, your creatinine is 1.4, 1.5, don't do a CT angiogram. And you suspect coronary, do an angiography, because we can do an angiography in 30 cc of dye. All right. Whereas a CT angio will take at least 70 to 80 ml of dye. So the contrast use definitely can be compromised in a coronary angiogram. So that depends upon the cardiologist, the way he does it. You can really compromise it. In terms of the radiation exposure, today's CT angiograms are relatively safe, but probably I wouldn't recommend repeating CT angiograms every year as a routine.
One question here. Many patients, as you said, come with a CT angio to you, not advised by you. If the CT angio shows 50, 60% lesions, LAD, RC, etc., patient is asymptomatic, you do a treadmill is normal. Do you give anything like aspirin or statin?
I would give aspirin.
If you find a block?
Yes. I would definitely give aspirin and statin to these patients. Maybe not dual antiplatelets, but definitely aspirin and statins.
Once atherosclerosis is demonstrated.
Yeah.
The next question is by Dr. Pandya.
Hello, sir. Good morning.
Morning, sir.
Many times we are the first call person for chest pain. Clinically, if we suspect that it is acute coronary syndrome, what protocol should we follow? And if elderly, very old, come with the same things, would there be any change in that protocol?
The first thing that you do is, of course, an ECG. See what is it. What is the underlying symptom? Is it an NSTEMI or is it a STEMI? If you have NSTEMI, you have time on your hands. If it's a STEMI, you need to work fast in terms of revascularizing the patient. Sorbitrate sublingual is the fastest thing that you can give. Disprin in this thing is the fastest thing you can give. Avoid Clexane unless you've made a diagnosis, because very often if a patient has to be taken in for an intervention, then Clexane interferes with it. You can always give a second antiplatelet, a load with clopidogrel, which is a class 1 indication today. Ticagrelor and prasugrel should never be given before a procedure. Ticagrelor, some evidence that it can be given as a loading dose, but clopidogrel and aspirin are the simplest things. Do an ECG and then base your decision based upon what the ECG shows. If you ask about a very elderly, I would say that treatment for the very elderly will depend upon various factors. One, what is his status of mind? Is he fully normal? Absolutely, this thing. How physically active is he? What is his? Does he have multiple comorbidities? A patient with cancer, a patient with end-stage liver disease, end-stage malignancy. The treatment changes. Your aggressiveness changes. What is the patient's will to live? I can't write off a 75-year-old or an 80-year-old because, oh, he's old. But the patient may want to live, right? That is extremely important in the geriatric population. You need to know what the patient's state of mind is. So if all these are taken into consideration, I would treat that patient as I would treat any other normal individual.
Sir, can I ask one more question?
Yeah.
Regarding, many of us do not have ECG machines. So in that scenario, should we go ahead if we suspect clinically with this protocol? And before giving survival, is it a must to check BP?
Always. Always. I would presume that when the patient comes to the clinic, the basic checkups are already done. Pulse, BP, saturations, etc. Inferior wall infarcts, if you give sorbitrate, you may precipitate a precipitous fall in the blood pressure because of vagal stimulation there. So some patients you are very cautious in giving sublingual nitrates. Never give the patient sublingual nitrate in the standing position or make him stand after giving the nitrate. He may just drop down in your clinic. So there's a small thing that you need to look at when you give these patients nitrates. But you can always give the patient Disprin. You can always give the patient clopidogrel. And of course, a sublingual nitrate if the situation demands. Rule out that you're not dealing with any gastric bleeds before you give any of these drugs.
We'll take the next
Statin,
question.
no. Statin, I wouldn't, there's no harm, there's no need to give a statin immediately. It doesn't get dissolved so fast.
Sir, you asked the second question from the next person.
Dr. Subodh Nadkarni.
Dr. Nadkarni is there. He is tall and unmissable.
Good morning, sir.
Morning.
So PAMI or primary angioplasty for myocardial infarction has become the standard of care for ST elevation myocardial infarction. Please tell us what happens in PAMI.
See, primary angioplasty means what? You try, when you have an infarct, when you have a ST elevation infarct, you have an occlusion of a vessel. You need to revascularize the vessel as soon as possible. The goal of treatment is a door to balloon time of 60 minutes. What is door to balloon time? Door to balloon times means the period of first medical contact. That means when you meet the patient for the first time, from there on, if you revascularize the patient in 60 to 90 minutes, then you are achieving a goal of revascularization of preventing damage. We do a primary angioplasty to prevent death of muscle. You can thrombolize the patients also. You can send the patient for a primary angioplasty. Now, there is enough evidence in Indian patients and in a lot of Indian studies, especially from Tamil Nadu and Kerala, which are based upon the pharmaco-invasive therapy. Pharmaco-invasive therapy is that you thrombolize the patient immediately, and in the next 3 to 24 hours, you take the patient for an angioplasty, for an angiography and subsequent angioplasty. Very often, what I see in practice is that patients, everyone goes gung-ho on primary angioplasty. And very often the patient is waiting in the casualty for 2 hours, 1.5 hours, 2 hours, 2.5 hours, waiting for the cath lab to get free. That is not primary angioplasty. You're causing more damage to these patients by doing a primary angioplasty in these patients. Thrombolize the patient in case the hospital is not available or the cath lab is not available. Thrombolize the patient immediately. Take the patient maybe after 3 hours, 6 hours for a procedure. That also is equally good. Primary angioplasty entails basically passing a wire through the block and opening up the narrowing, re-establishing blood flow. Re-establishing blood flow does not mean that you get a patent artery. It also means that there should be enough blood supply to the muscle, what we call as a myocardial blush. And there is something called as TIMI grade 3 flow, which is a thrombolysis and myocardial infarction grade flow, which means the flow down the artery is good. Similarly, there's a tissue myocardial perfusion grade, which shows how much of the based upon how much of the muscle blush is there. That tells you what is the eventual result of a primary angioplasty, not the patent artery. Artery may be patent. If the blush is not there, your muscle is gone, is dead.
So again, what is the term used for thrombolysis followed by angioplasty? You said
pharmaco-invasive.
Pharmaco-invasive.
Pharmaco-invasive. So
you do both.
First thrombolize and then you take the patient.
Is there any increased risk?
No. In fact, the benefits are, there are enough studies show that there is no change in the overall mortality in these two categories. PAMI on time versus pharmacoinvasive therapy.
Dr. Subodh, you wanted to say something? Okay.
The next question is with Dr. N.K. Kumar.
Hello. Good morning, sir.
Last way we'll take some questions.
Many patients have been put on dual antiplatelets after angioplasty, and they come to us for follow-up. They are continuing on the same two drugs. At what point of time do you consider stopping one of the drugs?
The European guidelines and American guidelines indicate that dual antiplatelets should be given only for a period of 1 year after a routine angioplasty. For complex procedures today, we do left main angioplasties, multiple stents, bifurcation stents, etc., etc. Now, in these patients, we do consider giving the dual antiplatelets for at least 18 months, sometimes in very high-risk patients for 2 years. In very elderly patients, beyond the age of 75, I would give it only for a year and a half maximum. I would stop it. If the patient is unknowingly on dual antiplatelets, we try and stop the antiplatelets. Or if the patient is on ticagrelor or prasugrel, definitely stop it at 1 year, change over to clopidogrel.
This is in above age 75. You would stop it 1 year, irrespective of the complexity.
No, about 1.5 years.
If it was a complex angioplasty.
We go by the symptoms in the patient.
The basis of this question was that we see many CTOLs.
Yeah.
Even by cardiologists after years. Should that be corrected by us?
You should be corrected, and in fact, you can always talk to the cardiologist, because in case there is if the patient lands up in a bleeding episode, you can land up in trouble. Because there is no guidelines which tells us that we need to continue dual antiplatelets unless the patient is recurrently symptomatic.
Correct.
The next question is Dr. Shah.
Are indications of doing angioplasty or CABG different in the elderly, and can we be more conservative in an older person?
In the elderly patients, yes, you can be conservative if the patients, depending on the patient's symptoms. What I tell my patients is that whenever we do an angioplasty or a bypass surgery, we do not guarantee life. We are not gods to guarantee that I'm going to give you 10 more years of life or 20 more years of life. What we try to do is try to improve the quality of life. And unless the patient is symptomatic, he will never, you never know what the quality of life is. So if the patient's quality of life is bad because of the symptoms, we should not, and there are no other major issues, and the patient is willing to take the risk. Of course, angioplasty or bypass surgery, both can be offered to a patient in the elderly age group. Angioplasty sometimes is preferred over bypass surgery because of the morbidity associated with a bypass surgery. Frailty of the patient, a very frail patient, a very underweight patient. Now, these patients you may not send for a bypass surgery because, of course, these patients, the risk is extremely high. Otherwise, it basically depends upon the patient's symptoms and what how fit the patient is in terms of deciding whether you want to send the patient for an angioplasty or a bypass surgery. The basis is quality of life.
I'll ask a rebound to the audience here. Asking all of you to raise your hand if your answer is yes. If a patient who's 75 has triple vessel disease and what they call chronic stable angina, stable meaning the problem is not worsened for several months of angina after 3 or 4 rounds of Jogger's Park. If such a patient has triple vessel disease of 70%, 70%, 70%, and the patient is otherwise well preserved for surgery or for angioplasty, how many of you will advise such a patient to go for a multi-vessel angioplasty or bypass? I'll repeat, chronic stable angina, significant lesions in all 3 vessels. How many of you will ask the patient to go for intervention? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Yeah, so what is your message in this particular situation so that we learn more from what you already said?
In chronic stable angina, there have been studies which have shown that treating these patients does not make a difference to their outcomes, long-term outcomes. When we do, we always, see, the thing is that we never know when a chronic stable becomes an unstable patient. So we always put it on the table to the patient. Make the patient a part of the decision process. Tell them that this is the option. You can remain on medications. This is another option in terms of getting it treated. What are the downsides of treatment in a chronic stable? Chronic stable can become unstable at times. If it does happen, seek medical help and treat yourself. Doing a surgery or an angioplasty, yes, there are recurrences with angioplasty. There are sudden deaths after angioplasty. There are sudden issues with surgery also. So that has to be put on the table. But if the patient is walking 4 rounds of Joggers Park, no major symptoms, has incidentally got these blockages with chronic stable angina, you still have the option of leaving them on medical therapy.
Next question.
Dr. Narayan Brijwani.
Good morning, sir.
Morning.
In geriatric hypertensive patients, when should we investigate for the secondary causes of hypertension?
In
Geriatric hypertensive patients.
Yeah. In geriatric hypertensive patients, most of the times there's usually no secondary cause for hypertension. Very rarely do you get will you get a geriatric with a secondary hypertension. Any hypertensive patient, run most of your investigations. Never run short of the investigation. At least do your basic renal profile, your CBCs, your liver profile for albumin, globulin, etc., and look at these parameters. They will give you an answer if you're suspecting anything secondary. A routine ultrasound will always pick up any renal issues in terms of size difference in the kidneys or anything which may give you a prompt as to what to investigate. This thing that we have sometimes seen in elderly patients is hyperaldosteronism. And these are patients typically with a very low potassium in spite of being on ARBs or ACE inhibitors. The potassium levels are still on the lower side. That should give you a bit of a thing that, oh, there's something wrong in this. The potassium should have been high in an elderly patient because renal parameters always start to decline in elderly hypertensive. Most of the elderly hypertensives have some renal thing. There's loss of sodium reabsorption. There's potassium accumulation in these patients. So these patients, when they are present to you with a low potassium, be a little suspicious that you may have this thing. But otherwise, most of these are essential or isolated systolic hypertension of the elderly.
Next question, Dr. Neha Sampath.
Good morning, sir.
Morning.
My question is, an 80-year-old gentleman has a persistent blood pressure of 200/80. How do we know if this is true hypertension or pseudo-hypertension related to old age?
Well, that's going to be a very, very difficult target to catch because I don't have too much of information. I don't have too much of this knowledge on this thing. But I would say that pseudo-hypertension is what? Because your arteries are very stiff, so they become non-compressible. The brachial artery is non-compressible. Typically, one way of differentiating pseudo-hypertension from true hypertension is the brachial ankle pulse wave index, which is the ratio of the pulse wave velocity in the upper extremity to the lower extremity. But I don't think those machines are so easily available that you can calculate that in your clinic. I would go by measuring looking at the end organ effects of these patients and seeing if there's any evidence of end organ injury. If there is evidence of end organ injury, then these patients are hypertensive. Very often we chase these BP targets only to know that the BP is still not coming down. So check the blood pressure in both the upper extremities, check the BP in the lower extremities, also in these patients, and then decide whether these patients are, how aggressive you treat these patients. The other thing you can also do is send these patients for an X-ray or a screening where you can actually catch the calcified vessels on the X-ray or an X-ray screening.
Nice.
Dr. Sheila Rathod.
Good morning, sir. Sir, how is the choice of antihypertensives different in the elderly, especially in the elderly with isolated systolic hypertension?
In the elderly, previously there used to be a situation where diuretics used to be the treatment of choice. But in terms of diuretics as a treatment of choice in the elderly, you need to be very, very careful about hyponatremia in these patients because, like I said, hypertensives in the elderly age group, the renal parameters are already dysfunctional. So there are certain situations where patients will lose sodium or they get into a form of dilutional hyponatremia. ARBs are usually the treatment of choice in patients with isolated systolic hypertension in the elderly. The second group of drugs that can be useful are calcium channel blockers. So the drugs you don't use in these patients are alpha blockers, drugs like minipressexone. Another drug that we have found quite good in these patients is going back to the olden days and going into central alpha blockers, that is clonidine. You get moxinidine now, but I have never found moxinidine to be as effective as clonidine in the treatment of hypertension.
What about beta blockers, sir?
Beta blockers, again, you need to be aware, is not the best treatment in these patients because you need to be aware of what the rhythm is. Any patient with a PR prolongation, be very careful with beta blockers. And these patients tend to react much more in terms of fatigue and tiredness with beta blockers as compared to the younger age group.
Thank you, sir.
Yeah, Dr. Bhavin Furia.
Good morning, sir.
Morning.
In elderly hypertensives with postural hypotension, we often have to deal with tricky situations where patient may have a sitting BP of 180 systolic over 80 diastolic and standing of 140 systolic and 60 diastolic. In such, how do we target the treatment?
I would go moderate somewhere in between. First, I would like to see what the reason for the postural hypertension is. If there is something, treat it. Give prophylactic measures for postural hypertension, stockings in these patients, and advise them regarding sudden changes of posture. And once that is done, probably you will be able to take care of a lot of it, this thing. Treatment of hypertension is also necessary. But our goals of therapy in these patients should be to keep the blood pressure around 140 to 150 and try and treat the postural hypertension also at the same time. We don't want to get the BP down to 120, 130. This, especially in the elderly, a BP of 120, 130 goal is not advisable because there are studies which show that once you get the BP down to those goals, the mortality is much higher in these patients. So our goal of therapy in these patients is about 140 to 150 systolic. Treat the postural hypertension, use stockings liberally and they're extremely good in trying to prevent postural hypertension. Find out the reason for postural hypertension in these patients, if you can find any.
Dr. Bhairavi Shukla.
Hi. So we are used to using amlodipine, but there are many drugs in this group which are also being used. So what do you think about them as far as clinical relevance of these is concerned, and which is your favorite?
My favorite, I'll start from the back. My favorite still remains amlodipine and S-amlodipine. In terms of blood pressure correction, in terms of blood pressure effects, I think these drugs still hold a much more sway over the newer drugs. Cilnidipine and effonidipine have come in as L and N calcium channel blockers and L and T calcium channel blockers. In terms of better effects on the kidneys, lesser side effects on the edema feet that calcium channel blockers cause. Are these drugs effective? They're effective. I don't think there's anything stopping you from using these drugs. I think it's what the patient tolerates in that this thing and how good a blood pressure control you can get that will determine what drug you use. Don't stop or you don't need to follow the crowd. That everyone is prescribing effonidipine, so let me also prescribe. Or a MR comes to you and says this is a L and T calcium channel blocker, better renal side effects, better this, better that. Every patient is individualized. Some patient may tolerate Cilacar better. Some patients may tolerate amlodipine better. My personal effect, this thing with cilnidipine has been that it's not the blood pressure controls have not been great with cilnidipine as compared to plain amlodipine or S-amlodipine, that is the S isomer of amlodipine. Yes, the side effects are much more on those patients, but then you need to titrate the dose in these patients.
So the next question will be, so can you tell us the appropriate use of each of the 4 beta blockers that are popular at present? Metoprolol, nebivolol, bisoprolol and carvedilol.
Except carvedilol, the other 3 are selective beta blockers. Carvedilol has an alpha-1 blocking activity also, and it has a beta blocking activity also. Now, metoprolol is the shortest acting of all these drugs. It has a half-life of 4.5 to 6 hours. So it doesn't work. If you need you need to give something in a very small dose, which you can reverse immediately. You give metoprolol. Bisoprolol is more effective. It's quite effective in reducing the heart rates, much more than the other beta blockers, and also is relatively selective. And it's one of the best drugs that you can give in asthmatics and patients who have issues with the beta-1 blocking activity of the beta blockers. With metoprolol in high doses, it has a problem with beta-1, it blocks the beta-1 receptors also. When it blocks the beta-1 receptors, you'll have side effects in terms of worsening of asthma and bronchial and bronchospasm. So that's one this thing. In cardiac failure, all these drugs can be used, though carvedilol has the maximum studies done in terms of cardiac failure. Metoprolol succinate, not metoprolol tartrate. Metoprolol succinate is also a good drug in patients with congestive heart failure. In terms of hypertension management, bisoprolol, nebivolol are better because they are longer acting. Carvedilol also has a better effect on the blood pressure than on the heart. More effect on the blood pressure than the heart rate. But carvedilol we selectively use in patients with heart failure.
So the next question is, as the aging population increases, atrial fibrillation is only going to be encountered more frequently. As general physicians, what should be our role in such cases?
Remember one thing, atrial fibrillation is something which you don't need to get very worried about. It's one rhythm which has never caused a cardiac event. Yes, it can cause a stroke, but never causes a cardiac event. Rate control is as good as rhythm control. Of course, you can get a rhythm control, well and good. But if you don't get a rhythm control, you can always control the rate in these patients and maintain these patients on medications. The question comes in terms of what medications that can be used. To control the rate, you can use diltiazem as one of the drugs. You can combine diltiazem with cardaron. But mind you, when you give cardaron, please monitor three things: thyroid, liver functions, pulmonary functions. These three things have to be monitored in the elderly, especially when you're giving amiodarone. The third drug that you can give, but not from the general practitioner's perspective, is flecainide. But that should be given only once you rule out that there is no coronary artery disease. There should be no coronary disease when you give flecainide to these patients. The next point is anticoagulation. What is the guidelines say that any patient, even if the patient is elderly, you should anticoagulate patients with atrial fibrillation, unless there's a specific contraindication. So there are two scores which are available on the net, which is one is a CHA2DS2 risk score and one is a Has-Blood risk score. Look at those scores. If the Has-Blood risk score is more than 3 or 4, do not anticoagulate these patients. Leave them on aspirin or medical therapy. If the CHA2DS2 risk score is high and the Has-Blood risk score is low, you can safely give these patients anticoagulation with the thing that this is a drug you need to be careful about and avoid falls, because the biggest risk in elderly patients is a fall.
Okay. So what are the best physical exercises that are geriatric friendly and good for the heart and the coronaries?
I think basically just walking, swimming, and static cycling. These are the best exercises. Some muscle strengthening exercises with light weights is also feasible if the patient is not frail and can withstand those exercises.
Okay. So and the last one, can preventive cardiology become a general physician's area of expertise? How do we go about achieving the same?
I think you people are the most important part of it, and I'm not saying I'm sitting in because I'm sitting in front of you. Because you are in touch with the patients on a regular basis. You are the first point of call, and you are the first, and you are the people the patients trust with their lives. They don't trust us as much as they trust you. And therein, you can always start modifying the lifestyle of the patients right from an adolescent age. And that's where you need to start modifying the risk factors. If you need to achieve something by the age of 35, 40. Today you're seeing youngsters in the age of 35, 30, 35, 40 coming in with infarcts and coming in with this thing. Risk factors have changed. The spectrum of risk factors have changed. Women smoking is increasing. Drug use is increasing. I think preventive cardiology would definitely start from the household level, not from the clinic. So I think if each of you can educate your own patients' families in terms of how to manage their lifestyles, how to moderate lifestyles. I'm not saying that you give up everything and sit at home. How to moderate lifestyles, how to change, how to avoid childhood obesity, how to avoid over binging of fast foods when you're young, and the common thing is when a child cries, just give a ice cream or something. So I mean, these are small things which you can inculcate in patients and start this as the basis of tomorrow's population.
Thank you, sir.
Thank you so much, Ajit. Before we leave, of course, a big round of applause, I think, is... so this new format, of course, is the interview lecture is a new format that we have been trying.
No, I think this is a better format than...
You think
I think
so?
individual lectures, half of them will be sleeping.
Okay.
And I mean, I sleep in conferences, so I am telling you.
Some of them are still sleeping, so I would like you to sing for us. A small song by you would wake us all up. Ajit is a romantic guy and he usually sings romantic numbers which are, so...
Sorry?
माइक तो है सर के पास, दूसरा माइक चाहिए?
हाँ? नहीं,
थोड़ा लाउड करना है, थोड़ा.
मुसाफिर हूँ यारो, न घर है ना ठिकाना, मुझे चलते जाना है, बस चलते जाना. मुसाफिर हूँ यारो, न घर है ना ठिकाना, मुझे चलते जाना है, बस चलते जाना.
His voice has a Timmy 3 flow. Thank you so much. I will just greet you with a small gift.
Thank you everyone for having me over. It's a privilege, and I thank Tushar so much. He's been I don't know how many years I know him, but many years. And I'm so proud of what he has become and what he's done. And a heartfelt thank you to each and every one of you here. Thank you so much.
Thank you, sir.